My name is Alan Prost, and in this video, I'm going to be exploring driving pressures and its association with mechanical ventilation. Primarily, I'm talking about the mode of pressure control when it's being utilized to ventilate patients with adult respiratory distress syndrome. Why I'm talking about driving pressures is because it's been outlined by many authors. You'll see a short reference list at the end of the video, and its association with ventilator-induced lung injury. So I'm going to look at what we're manipulating when we manipulate driving pressure, what happens with the patient, and then I'm going to be making a few recommendations for potentially for some further study on the subject.
So in this video, I'd like to discuss or consider a few questions. The first one, I'm going to hope to demonstrate some of the effects of altering driving pressures in mechanically ventilated patients. So we're going to look at several modes, and I'm going to try to demonstrate for you what happens when we alter driving pressures or pressure control levels. And the reason I'm doing that is because I'd like to consider, do high inspiratory flows result in increased shearing forces being delivered to the lung? And does this have a result on ventilator-induced lung injury? So that's the big question I'd like to answer. And of course, I don't have enough information to do that, but I'd like to maybe have some other people out there consider that and do some studies on that. So how can inspiratory flows be reduced in mechanically ventilated patients? And I'm going to show you a few strategies on that. But the big question that we have for us is, in a clinical question, is it the shearing forces? Is it just keeping the pressures low in the lungs? What's the major factor contributing to ventilator-induced lung injury? So within this video, we're always going to be considering the critical goals of mechanical ventilation, which is to always maintain oxygenation and control the pH of our patients. So those are given parameters that we're going to be adjusting clinically. So I'm not going to discuss those in this video. We are going to be talking about keeping the pressures less than 30, or P plats, as compared to the PIP. That's important to distinguish the difference between those. And of course, it's the P plats that we want to minimize in our ventilated patients. When we talk about limiting lung pressures, we're going to limit the pressure control level, and that's controlling the tidal volume delivery to our patients. So there's a concept that we want to always be thinking about, and it's that 6 to 8 mils per kilogram is what our goal is for most of our patients. And then I want to consider limiting driving pressures, and we're going to be exploring that. So within this video presentation, I'm going to be assuming that you understand that I'm going to make sure that the critical goals of mechanical ventilation, such as minute ventilation, limiting the P plats, assuring adequate pH control, are givens, and that we're going to be examining the strategies to limit driving pressure used to achieve these goals. So any of the suggestions that I'm making about maintaining or changing driving pressures, it's assumed that you would know how to alter the rate and tidal volumes to achieve the therapeutic goals for the patient. Where I'm going to be exploring a little bit is to suggest that the goal of limiting driving pressures may be an inspiratory flow limiting strategy. All right, that might be the outcome. Yes, we're always trying to keep the pressures in the lungs as low as possible with our tidal volumes, but maybe a contributing factor to ventilator-induced lung injury is that these inspiratory flows might be a critical factor in controlling the shearing forces that may be responsible for ventilator-induced lung injury, contributing both, of course, to overpressurization and limiting our P plats is the way we're going to control that. On this slide, what I'm demonstrating is the mode of pressure control, and we've got flow, pressure, and volume being demonstrated here, and I use the ASL 5000 with an Evita XL ventilator. All right, so the ASL 5000 is how I derive these waveforms, and that was being utilized as our kind of standardized patient. All right, so what I did with the ventilator is I changed the driving pressure, the pressure control level, and I kept all the other parameters, such as the compliance of the patient's lungs, and the resistance, I kept those parameters the same. All right, so as we increased the driving pressure, we noted that, of course, with the compliance being the same, that when we induce more pressures, we're going to get larger tidal volumes as we increase those. We'd expect that. What I also wanted to demonstrate, more importantly, is that we have this increased in peak inspiratory flow. All right. So with keeping the compliance the same, and of course the resistance is mainly due to the endotracheal tube, and we see that as we increase driving pressures, we're going to increase tidal volumes, and we're going to increase peak inspiratory flows. So in this slide, I'm just exploring that same relationship. I'm just focusing in on the relationship between driving pressures and peak flows. All right. So as we increase driving pressures, we of course expect the tidal volumes to be increased. And I'm looking at the flow and the pressures just in a little bit more detail. All right. So as we increase that driving pressure, all right, so that's the pressure between the baseline, which is usually PEEP, and our pressure control level, that driving pressure induces an inspiratory flow. And it's the reason that it's shaped the way it is. So we get this peak inspiratory flow being delivered here, is that because initially at the start of the breath, we're having a large pressure gradient between the circuit pressures and the pressures in the lung. And the pressures in the lung are shown to us in the yellow line, and the pressures in the circuit are in the orange line. We're lucky with the ASL 5000 we can demonstrate those different waveforms. All right. So initially we get this high peak flow, and then it continuously declines as the pressure in the lungs approaches the pressure in the circuit. And that's a critical component. So the reason that we have this logarithmic decline in inspiratory flows is because as the pressures in the lungs approach the pressures in the circuit, we have a decrease in flow. Remember that flow is the result of the change in pressure over resistance. In this case, the resistance is mostly induced by the endotracheal tube, and the delta pressure initially is high between the lungs and the circuit, and then as the lungs fill, that continuously decreases until we get to the point where we have that inspiratory plateau where the flow declines to zero. All right. So needless to say that as we increase this delta pressure, we're going to get higher peak flows. An important consideration is that the time it takes to get equilibrium between the circuit pressures in the lungs does not change even though we increase the driving pressure. The time for equilibrium in both of these situations, even though we have the increased driving pressures, is the same. And that's because that's due to our time constant, which is the time constant is equal to our compliance times our resistance. And most authors agree that it's usually about 3 to 5 time constants that result in equilibrium between mouth pressures and circuit pressures. And then we have our little bit of an inspiratory plateau here because we've established that with our TI control on our ventilator. So the highlight of this particular slide is what I wanted you to realize is that when we increase driving pressures, we increase peak inspiratory flows. So by limiting our driving pressure, so when we keep our driving pressures quite minimal, we minimize our peak inspiratory flow. Now in this slide, we're still in the mode of pressure control. We still are showing our flow and our pressure gradients, and here's our volume as well. And what I've done here is I've maintained the same driving pressure in all three situations, but I've altered the compliance. So with each of these, I've increased the compliance dramatically. And of course, if you look back the other way, you can say I've decreased the compliance. So I've kept the resistance the same because that's about similar to the resistances we'd find on the endotracheal tube. So needless to say, as compliance improves, as increases, we see for the same pressure gradient an increase in tidal volume. And we can see that distributed here. But what's very important to realize is that the peak inspiratory flow remains the same. All right. So if we maintain the same driving pressure, we maintain the same peak inspiratory flow, regardless of the patient's lung compliance or the tidal volumes delivered. What does get altered, of course, is our time constant. All right. So the time for equilibrium with the time constant here is going to be increased with increased compliance. All right. So maintaining the same driving pressure does not change the peak inspiratory flow, but what it does do is it alters the time constant, or the time it takes to get equilibrium between circuit pressures and mouth pressures. And that's an important consideration. So when we minimize the driving pressure, when we keep that the same, we can have, depending on the patient's compliance, different tidal volumes, but the flow rate is directly related to the driving pressure. And we know that from examining that equation where flow is equal to the change in pressures over resistance. And in this case, our resistance is pretty well maintained by the endotracheal tube. So in the mode of pressure control, it's important for us to demonstrate and to realize that the pressure control level is the only mechanism we have to limit the inspiratory flow. All right, so the pressure control level, which is the driving pressure, is our mechanism to decrease both tidal volumes and inspiratory flows. Yes, it limits the P plats, which is an important consideration because we don't want to have overdistension. Yes, it controls our tidal volume delivery. So all of those components are important to realize, but I wanted to make the association with the inspiratory flows. Changes in the patient's lung compliance alter the tidal volume, but have little effect on the inspiratory flow. It's all about the delta pressures, or the pressure control level we set on the ventilator. So the reason the inspiratory flows are initially very high is because we initially have very high pressure gradients between our pressure control level and peak, between the lungs and the circuit pressure. So the reason we get that logarithmic decline in inspiratory flows is because we have that slow filling of the lungs, and as the pressure between the circuit and the lung pressures become closer, the flow declines until it eventually gets to zero. The TI dynamic, the amount of time it takes to get equilibrium between lung pressures, is the result of our time constant, which is going to be, of course, the function of our resistance times our compliance. Usually about 3 to 5 is considered to get maximal lung inflation. So from our previous slides, we looked at pressure control, and we saw that the way we could control peak inspiratory flow was with our driving pressure. But we compare that to volume control, we have direct control over our flow rate. So in this comparison on this slide here, we see flow over pressures, and I'm focusing on the flow today. We've maintained a tidal volume for all of these situations to be the same, 500, and I've got the same compliance and the same resistance for all of our test situations. And what I've done is I'm comparing the pressure control mode where we're receiving or achieving a peak inspiratory flow of about 60 liters per minute. And then I'm comparing that to the mode of volume control where I control the flow rate and I'm continuously decreasing that flow. You'll note that our P plats, the pressures, because the tidal volume delivery is the same, is going to be the same in each of these conditions. The peak inspiratory pressure is going to be altered because the difference between the P8 plat and the PIP is due to resistance, and we've kept that the same, but I'm altering the flow rate. All right, I've controlled the inspiratory pause on this so that our TI, as established on the ventilator, is 3 seconds in all conditions. All right, so the time for the TI is being maintained. Our tidal volumes are being maintained. Our mean airway pressure is being maintained. The only thing that's changing is our peak or our flow rates. So in each case, we are using lower flow rates, achieving the same tidal volume, the same minute ventilation, the same mean airway pressure, but we're dramatically decreasing those shearing forces, is what I'm suggesting, by limiting our inspiratory flows. So when we looked and compared pressure control to volume control, we can see some quite a few differences in volume control. Volume control mode allows us to directly control that inspiratory flow. All right, we can achieve the same P plats, the same minute ventilation, the same inspiratory time, the same mean airway pressures, all those critical factors to control the P plats of the patient and minute ventilation and control pH of our patient are being achieved the same as they would be in pressure control. All right, the difference is that we can have very low inspiratory flows, and this may be important to limit ventilator-induced lung injury, and that's what I'm suggesting today. So volume control may cause patient ventilator dyssynchrony. And why I'm talking about that is because during that inspiratory pause, that time where the breath is going in, the patient cannot breathe in volume control. So sometimes if the patient's awake or alert, they may be trying to breathe during that time, and that's limited in volume control. So there may be some ventilator patient dyssynchrony. That could be a concern. Of course, if we're going to talk about modes of ventilation, we can't get away without talking about PC adaptive, or pressure regulated volume control, as some people know it. In this mode, we set a volume target, all right? And then the ventilator decides on the driving pressure necessary to deliver that volume target. And of course, that's going to be controlled by our compliance and our resistance. The resistance is going to be, effects of resistance are going to be minimized because we've got a long enough TI to get equilibrium and our inspiratory pause in each of these situations, all right? So another way we can control our peak inspiratory flows, is what I'm demonstrating for here, is by setting this slope or inducing a little bit of resistance during inspiration. And that's what adjusting the slope does in the mode of PC adaptive, all right? So we can still get all the benefits of using a pressure control focused mode with a volume target and still limit our peak inspiratory flows, all right? As I increase the slope or induce more inspiratory resistance, we can dramatically decrease that peak inspiratory flow. And I'm making the assumption that there may be a relationship between peak inspiratory flows and shearing forces in the lungs. And of course, limiting that may reduce those shearing forces and reduce ventilator-induced lung injury. So I've given you another strategy here to limit peak inspiratory flows or mean inspiratory flows. So using PC adaptive is a very good mode because it gives us our volume targets. We still get that long inspiratory time. And in PC adaptive modes, we can control that peak inspiratory flow by controlling the inspiratory slopes, or by inducing, it depends on the type of ventilator, they call it different things, but by inducing a little bit of inspiratory resistance, we can modulate that inspiratory flow to limit that, so we can potentially decrease shearing forces. The nice thing about PC adaptive is that the patient is allowed to breathe at any time. So the ventilator dyssynchrony with the patient is reduced. And we can still use this mode to reduce inspiratory flows. We can reduce the shearing forces potentially and limit ventilator-induced lung injury by limiting those peak inspiratory flows. And that's a suggestion that we should be considering studying. So some of the conclusions that I'd like to make today: if the critical component of ventilator-induced lung injury is lung pressures, then the existing strategies to limit lung pressures, and with low lung volumes and low driving pressure strategies, are our best practice. But I think we can contribute to that discussion a little bit if we consider that ventilator-induced lung injury may also be the result of shearing forces, and there's several authors you see in the references that are discussing that point. Then we should consider utilizing and limiting inspiratory flows to, in combination with that, to limit induced lung injury during mechanical ventilation. So I'm suggesting that maybe we should study that in a controlled environment. So what I'm suggesting, that if the goal is to limit shearing forces, then we've outlined some strategies that we could utilize to do this. We can use in pressure regulated volume control, or PC adaptive, we could use the TI rise control or the slope control to limit those peak inspiratory flows. All right. If we want to use volume control, we can directly control those inspiratory flows and have direct control and minimize them to the greatest advantage. We're a little bit concerned about patient dyssynchrony with that mode, but if the patient's unconscious or severely ill, maybe that's not a major consideration. So the big questions I'm proposing are shearing forces the critical component of ventilator-induced lung injury? Maybe we should take a look at that. Maybe we should set up some studies to decrease inspiratory flows and study the effects of those shearing forces. What is the optimal flow rate? Maybe we could distinguish what that is with more complete studies. If the goal is to severely limit inspiratory flows, and we could then determine maybe if doing that reduces the potential for ventilator-induced lung injury. So as promised, I've got a very brief list of references here. If you go into any database and just put in driving pressures or adult respiratory distress syndrome and mechanical ventilation, you'll come up with quite a selection of different articles. And we're going to see that many authors are looking at this association of driving pressures contributing to ventilator-induced lung injury. And I'm making the assumption that, along with a few other authors out there, that maybe it's the shearing forces that we should be looking at, and that might be associated with how quickly we allow the lungs to be open and closed, and we can control that with the mechanical ventilator. So my name is Alan Prost, and I've been discussing today the effects of driving pressure and mechanical ventilation, and making the assumption that maybe we should be considering limiting shearing forces by controlling inspiratory flows. Thank you very much for watching the video. Please contact me if you're considering doing any of this research. Thank you very much.